Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Hello everyone, welcome to today's INS podcast. The topic of today's podcast is challenging orthodoxy. What does it take? With me as my guest for this is Professor Sam Eldabe from Middlesex in the United Kingdom. Sam, lovely to have you here today.
Thank you, Mark. It's a pleasure to be with you.
Could I ask you just to introduce yourself and then maybe give a little bit of background in terms of where you grew up, medical school, and your early clinical practice?
Yeah, I'm Sam Eldabe. I am a consultant in pain medicine. I work at the James Cook University Hospital in Middlesbrough in the northeast of the UK and in Morges in Switzerland in Canton Vaud. I grew up in Alexandria, Egypt, and did all my medical studies there at the Orthodox medical school, old style, anatomy lessons, physiology, everything was done in the old style. And then after that, I did 3 years as a resident in anesthesia. And there I grew to love the idea of treating pain. We had a colleague who was a man who was gifted with an unusual ability. At the time, 1980s, no ultrasound, very little access to radiology, and he did celiac plexus blocks, believe it or not, without any image guidance. And the rate of success, I will tell you, was more than 90%. And when you see this, it is just such an amazing feat with a patient who is writhing in agony, pancreatic cancer. 5 minutes later, you think, wow, I have got to learn to do this. Unfortunately for me, I wasn't that gifted. I couldn't do it without image guidance, and I found that trying in Alexandria wasn't going to work. I had to go and learn the trade somewhere else. So I went to the UK and started my career in anesthesia, and within a year or two started exploring chronic pain as a career. At the time also chronic pain was not a big thing in the UK as it is now. But eventually I got into the northern region of the UK and got on the northern region rotation as a chronic pain trainee. It was at the time mainly train yourself, because our boss's training in interventional procedures was not that advanced. So basically you had to travel the country to learn to do a celiac plexus block here, learn how a spinal stimulator was done in Leeds, for example, etc., etc., eventually until you got enough under your belt to be able to say, yes, I can practice as a consultant.
Fascinating, fascinating. So our topic today is orthodoxy, and I guess what do you take as being orthodoxy? What does orthodoxy mean to you in medicine?
Medicine is unfortunately full of groupthink. We were brought up to believe that X leads to Y, and we don't challenge that, and most of the time we don't ask any questions because that is how it is. You were told that this condition leads to that condition, and then you start to practice and you realize that actually it isn't that straightforward. It's not always that X leads to Y. And it's always clinical practice that drives the question that one asks. And I found that through practicing and seeing what was published and what I saw in the clinic, I found that where there is discrepancy, there has to be an explanation.
And what do you think are some of the problems that orthodoxy can lead to if it is allowed to run rampant?
I suppose we end up with doing things that we may suspect are not particularly helpful. We end up doing procedures that are not necessarily required, but orthodoxy sometimes is impossible to fight against. You take the case of trials in spinal stimulation. We see that at the end of the day, the long-term outcomes of spinal cord stimulation is not predetermined by trials. I don't think will argue that this is not the case. But we still do them. It is dogma that you have to trial. It is dogma that patients want them. It is dogma that we challenged all this, and I think the UK now, the majority of practitioners do not trial, at least not straightforward cases. But in complicated cases, yes, by all means, I'm not against the idea, but I am saying that the science does not support the idea that trials predict long-term outcome.
So some people would argue, I guess, that, look, we have the scientific method, which is embedded in the sciences and embedded in medicine, and that's founded on the principles of investigation, testing, and then adopting a new or greater understanding. Why is it you think that alone isn't sufficient to guard against orthodoxy?
I think it is the problem with conducting and designing research is you have to start with a question. And it depends where your question is. If your question is in the balance on the side of orthodoxy, the answer is probably likely to favor orthodoxy. If your question is on the other side, then you stand a chance of getting an answer. I think every research project there is a certain bias in the design from the start.
What tools do we need, if you like, then, to try and counter orthodoxy?
I think you need a questioning mind, or to put it bluntly, an awkward personality, to ask questions where others haven't questioned the norm. And if you have that awkward leaning, you start to say, why? Why is it that you're telling me that this works better than that? Why is it that this is superior to that? And a lot of what we see in trials it requires you to sit and read the study a few times in order to exactly understand what has happened inside this trial. And a lot of us don't have the time to sit and read the methodology 2 or 3 times to see what's happened, how was this done, how were the patients blinded, etc., etc. All of this leads to questions. And once you start to question the methodology, you might be surprised at how good it is. But no trial is perfect. And you'll eventually come to a conclusion that you could have done this or you could have done that.
So do you think that this sort of aspect comes more from innate personality, comes from a formative experience in your youth, comes from slow accumulation of battle-scarred wisdom? Where do you feel it comes from?
I think a lot of it is a personality thing. It's a questioning of authority, if you like. If you have that kind of personality, you'll always question what is thrown at you. That is a beginning, but it does require some training afterwards to actually be able to ask the right questions, because there are plenty of people who do question research, but they're not reasonable questions. You have to have reasoned questions, and questioning research has to be done in a polite and reasoned way. That's the most important. We're talking science, we're not arguing politics.
Yes. Look, I think that's a very good point, Sam. I reflect on my own journey, and when I was studying maths at school, I used to challenge the maths teacher. Surely you must be wrong, surely this is this, surely this is that. So he nicknamed me Shirley and called me Shirley for a year. So I think I may have had an element of that myself.
Yeah, you understand how it works then. It's I think a personality trait that is then reinforced by learning. But
how have you gone about that in terms of the neuromodulation world then? What, if you take that aspect, how have you applied it to neuromodulation?
It's a question of observation. You, like me, see a lot of patients in a day. You finish your day with an impression of how well things are for these patients of yours. How are you served by this therapy? How are they served by this therapy? You then go and read literature, and if the two don't match, something isn't right. Especially if you are doing your best, then something isn't right. Then you have to ask the question, what isn't right? And if you come to the conclusion that it is not what you're doing, then you have to ask the question, why are we unable to achieve these outcomes? I come and ask you, Mark, can you achieve these outcomes? And you say no, and then my suspicion becomes stronger and stronger.
Have you had both positive and negative sort of experiences from engaging in this kind of reverse orthodox behaviour?
Yes, definitely. I think the world of neuromodulation, there is a lot of enthusiasm in the world of neuromodulation, and once you start to challenge the dogma that things work perfectly, some people become unhappy. But at the same time, I have had quite a lot of positive feedback when we speak at conferences from people who say, we like what you say because we know what you say is really heartfelt.
Yes.
And that's fine. I'll take the praise with a damning.
Exactly. What would your comments be on how to assist or encourage trainees to have this kind of mindset of questioning?
Giving trainees the time to actually be able to understand how to critically appraise a paper is useful, but that's not where it starts. It starts with your own practice. If a trainee is doing procedures, so let's say you're doing cervical medial branch blocks, you read the paper and it says pain scores down from 8 to 2. You keep doing them and the pain scores don't come down from 8 to 2, and most of the patients come out and say, ow. You then have to question as a trainee, am I doing them correctly? And it may be that your approach is too rough, that you're doing A, B, C, and D that is not correct. And if you then get the proper understanding, the proper training, and you're still getting the same results, then you need to ask the question, what's happening? Is it me? Is it that publication? They then start to enter into a sort of chain reaction that prompts them to do their own audit, then their own research, and they end up with their own conclusions, and that's great.
Yeah. Sam, this has been fantastic. I could talk to you all day. It's been an absolute pleasure having you on our podcast. Thank you so much.
Thank you. Thank you very much for having me.